We have a question about a haploidentical transplant for a person of mixed race for whom an MUD donor is said to be unlikely. Is it better to do that than seeking immunosuppressant treatment?
So that's a really hard question. So in the UK at the moment, our first line treatment is having a brother or sister who's a match. After that, for children, we either offer immune suppression or what we call a 10-on-10 match unrelated donor transplant. If you don't have a 10-on-10, then at the moment we're saying go for immune suppression and reserving haploidentical transplant if you fail immune suppression. Having said that, some countries are doing haploidentical transplants frontline, and it may well be that we will come to that, but we're not quite there yet in the UK.
Thank you. And then sort of extension of that question is, if immunosuppressant treatment is initiated, can we get horse ATG in this country like the USA, where the results are better than with rabbit ATG? And I don't know if anyone else might need a bit of an explanation about some of the differences between that in your answer to your question.
So we can get horse ATG. So just to give you a bit of background, ATG is made by injecting, you take a gland called a thymus. The thymus has T cells and many other immune cells in it, and you inject it into an animal. That animal then forms an antibody to those T cells. So you take human thymus, inject it, and they form antibodies to those T cells. And then the problem we had in the UK is about 15 years ago, the horse who was making all this horse who they were taking this sort of serum for the antibody for the ATG. They said the horse retired. I'm not sure exactly what happened to that horse. So we didn't have horse ATG around about 2009, 2008, something like that. So we had to go to rabbit ATG. Rabbit ATG didn't work as well as horse ATG. But certainly over the last 6-7 years, we've been getting horse ATGs. The brand name's called ATGAM, and that's what we use frontline for everybody here in the UK. So we don't have any problems with, shouldn't have any problems getting horse ATG in the UK that I'm aware of.
Thank you. And there's a question asking, how come not a transplant with a 9 out of 10 match before an immune suppressant treatment?
Again, so that's, so I was talking to another consultant in Newcastle about this earlier today. So the current UK recommendations are to go ahead with immune suppression rather than 9 on 10. Having said that, though, my own unit and many other units have also done 9 on 10 rather than doing immune suppression. So it's very tricky because you have to explain the pros and cons of doing immune suppression versus transplant. With immune suppression, the advantage of immune suppression is that most people, it's not pleasant, but after about 1 or 2 weeks in hospital, you go home, and generally people don't run into any serious life-threatening problems because of the treatment. The problem with the treatment, though, is that it works in about 50 to 70% of people. And when it does work, and that's a real problem, particularly for children, you often find that the blood counts improve, but they don't go back to normal. And if you want to go and do sports and things, that's a big problem. The other problem with immune suppression is that it can come back again. So in at least a third of people, it comes back again. And then there are other problems with the bone marrow where years down the line, it might run into other problems. We call that clonal evolution. So it's not, I wouldn't call it a cure. So at the moment, we say for ATG and cyclosporin, we often give it to people who don't have a good match donor. And if it doesn't work in 3 months' time, then we go to that donor. We use that transplant. The advantage of transplant, whether it's haploidentical or the 9 on 10 that you're talking about, is that if it works, we see that as a cure. Lifelong potentially as a cure. The downside of transplant is there are 2 problems. One, you can get a life-threatening complication. Typically happens up to about 1 in 10. And you can also get graft versus host disease, which is where this the donor's immune system attacks you, and that can cause problems as well. And that can happen about 10 to 20%. So you have to weigh up the risks and benefits of, do you want to take that risk of doing a transplant? And there's it's not a small risk, but there is at least 10% chance of something going wrong. But if it works, 90% on average it works, then hopefully you'll be cured. On the other hand, with immune suppression, it's very safe treatment for most people, vast majority of people, but it doesn't work that well. For about 1 in 2, it doesn't work that well. So it's about weighing that risks benefit and what do parents feel. So that can be, it depends on, because we don't know which one's better. We normally discuss this with the families and say, well, you've got one option here versus the transplant. And it depends on what people feel about those different risks. With a 9 on 10, at the moment, most of us are saying that those risks are probably a little bit too high. But as I said, many units, when you explain it to the families, they probably say, actually, you should go ahead with that transplant. So it depends upon people's views. At the moment, we're not recommending haploidentical transplants without prior immune suppression at this moment in time.
Thank you. There's a question around, with children, how long can remission last with immune suppressants?
So in principle, it can last, it can also last a very long time. The problem with immune suppression is that the disease can come back in at least 30% by 10 years, and that then and that doesn't stop. So what you'll find is after that 10 years, there'll be a proportion of more children who will continue to relapse. What we know is in about after 10 years, about 30%, I would say, would be completely okay. So 70% won't.
And is there an upper age limit, an upper limit for age of donor in the haploid?
There isn't an upper age limit, but the problem is that the older you get, the less, how can I put this? It is slightly ageist, I'm afraid, that you want young people's stem cells because they're the ones that are going to last the rest of their life. So you don't want, there's no official upper age limit, for example, of parents or something like that. But you ideally want a young person donating because you're less likely, I think, to run into problems. So those are the kind of things that a transplant team will look at. Age of the donor, any problems with the donor. For example, if it's a parent, we sometimes have parents who aren't fit enough to donate. So these are the things you've got to bear that in mind.